Hi, and thank you so much for joining us today. My name is Ruth Brignall, and I'm the Global Medical Expert at Oxford Immunotech. And I'm going to talk today about the T-Spot Discovery SARS-CoV-2 Research Use Only Kit. And I've talked a little bit on this topic before, but what's new is that there's a preprint now available on medRxiv, which is the first data which has come out, which has used the SARS-CoV-2 kit as an assessment of SARS-CoV-2 infection status and T-cell responses. So I'm going to talk a little bit about that data and more about the research use only kit itself. So this is just a quick disclaimer before I get started. The T-Spot Discovery SARS-CoV-2 kit is intended to detect and measure the strength of the T-cell response to SARS-CoV-2 infection using the T-Spot technology platform. The kit is currently designated for research use only. However, Oxford Immunotech has the intention to file for global regulatory approval as the use cases solidify. So now let's just talk a little bit about what I'm actually going to cover today. I'm going to talk a little bit about the current tests that are available for SARS-CoV-2 infection and what their limitations are. I'm then going to move on and talk about the role of T cells in the response to SARS-CoV-2 infection. And I'm going to change track slightly and talk about the principles of cell-mediated immunity in testing for SARS-CoV-2 and really the basis of using interferon gamma release assay in testing for SARS-CoV-2 infection. And finally, I'm going to talk about the T-Spot Discovery SARS-CoV-2 Research Use Only Kit and a bit about how the test works, and then move on to this study which has been released as a preprint in medRxiv, which is really focusing on the EDSAB home study. And from this data, I'm going to talk about the relationship between serology and the T-Spot Discovery SARS-CoV-2 results, and the implications of the T-Spot Discovery SARS-CoV-2 Research Use Only Kit in terms of the pandemic. And then we're going to finish with a question and answer session. So if you do have any questions while I'm talking, feel free to submit them and I can get to them at the end of the session. So firstly, I'm going to talk about the tests that are currently available for SARS-CoV-2 infection. And this really fits into two main brackets. And the first test is a test which tells people whether they've been infected with whether they're infected with SARS-CoV-2 right now. And this is done using molecular testing or polymerase chain reaction or PCR. And the way this works is that someone receives a nasal or a salivary swab, and this is done to look for little pieces of viral RNA from people who are currently infected with SARS-CoV-2. And this viral RNA is converted to DNA and it's copied and amplified in a process called PCR. And there are a couple of really great things about using PCR to test for SARS-CoV-2 infection. And the main one is that the infection can be detected really early on and that the samples can be processed really quickly. However, one of the big drawbacks of using PCR is that it can't detect people who have been infected and later recovered from the virus. And this is where the second type of test comes in. And this is a test to tell people whether they've been infected with SARS-CoV-2 in the past. And this is done using serological testing or ELISA. So what happens here is a patient becomes infected with SARS-CoV-2, and within a couple of days of being infected, they start to produce antibodies against the SARS-CoV-2 virus. And the first antibody that they start to produce is the early antibody, IgM, and they start to produce that within about 2 days. And this is a fairly non-specific antibody, and it's also quite a low-level response, and it's not particularly long-lasting. However, within a couple of days, they start to produce the later antibody, which is IgG, and this starts to be produced about 9 to 11 days after exposure to the virus. And IgG is highly specific to SARS-CoV-2, and it's also a really robust, really long-lasting antibody response. And these antibodies in a patient's blood or serum can be measured using ELISA methodology. And again, there are a couple of really good things about using ELISA to test for SARS-CoV-2 infection. And the first thing is that it can be a very rapid test and it can even be made available at point of care. But the main advantage is that it's able to detect people who have previously been infected with the virus and later recovered. So it's able to detect past exposure to the virus. One of the limitations that's been reported of using antibody testing to test for SARS-CoV-2 infection is that false negatives can occur if a patient has a delayed immune response or if they're able to eliminate the virus without antibodies, or as we're starting to see with SARS-CoV-2 infection, if that antibody response starts to wane after exposure to the virus. So just to look into this a little bit further, I'm going to show this schematic, and this graph isn't based on any real data and it's not drawn to scale. It's just a schematic which shows what's happening in the immune response during a SARS-CoV-2 infection. So what happens when someone becomes infected is the virus gets into their body and it starts to replicate. And this red line shows that the viral load starts to increase within the body. And it's during this time where the virus is detectable that PCR testing is really useful. However, once the antiviral response kicks in and the body starts to fight off the infection, the viral load will start to decrease. And this means that PCR testing is no longer useful because the virus is no longer detectable in the body. And it's during this stage of the infection or the recovery phase that antibody testing really becomes useful. So after a couple of days, we start to see this IgM response that I talked about, which isn't very specific and it's fairly low level and not very long lasting. And then a couple of days after that, we start to see this IgG response kicking in, which is a much longer lasting, much more robust and much more specific antibody response. But as I mentioned on the last slide, there are a couple of limitations of antibody testing. And the first thing is that depending on which literature you read, around 10 to 30% of patients appear to have no detectable antibodies against SARS-CoV-2 infection. Another problem is that mild or asymptomatic patients might have really low levels of neutralizing antibodies. And I'm not going to go into too much detail on this here, but neutralizing antibodies are the real functional antibodies which can bind to the virus and prevent it from entering host cells and replicating. So they're really the ones that provide some level of protective immunity against the virus. And most antibody tests that are available don't actually inform on the levels of these functional or neutralizing antibodies. So what this really means is that there's not currently enough data to confirm that antibodies are protective. And if they are protective, we don't know how protective they are or how long that protection will last. So what I'm going to do in the next couple of slides is just talk a little bit about some of the data which has come out this year since the start of the pandemic that talks about these limitations with antibody responses. And the first one that I've mentioned is that some patients do not produce detectable antibody responses to SARS-CoV-2 infection. And what's become really clear is that people who suffer from a mild or an asymptomatic form of the disease appear to produce lower levels of IgG antibodies than those who suffer from more severe disease. And this is shown really nicely in this graph here. So what this graph is showing is the levels of IgG antibodies that are produced in response to the S1 and the S2 subunits of the spike glycoprotein from the SARS-CoV-2 virus. And it shows the amount of IgG that's produced in healthy, asymptomatic, mild, moderate, and severe disease. And what we can see if we look at the black and the lilac bars in the middle of both graphs is that those who suffer from asymptomatic and mild disease often don't produce enough IgG antibodies to get them over the level of detection of the antibody tests. And what this shows us, and what several other studies have confirmed, is that some individuals who are PCR positive never seroconvert. They never get a positive antibody test. And they will always be missed or they won't be identified if we use serology testing. Another thing that's become clear since the start of the pandemic is that antibody responses to SARS-CoV-2 appear to decline over time. And recent reports have shown that antibody responses to the SARS-CoV-2 virus might not be long-lasting, especially in those people who suffer from mild or asymptomatic illnesses. Again, what we have here is a graph showing the amount of IgG which is produced in asymptomatic and symptomatic individuals. And we have these dark blue spots showing the IgG response of people in the acute phase, so when they're currently infected with SARS-CoV-2. And then the lighter blue triangles show people in the convalescent phase, so once they've recovered from the infection. And what we can see fairly consistently in this population is that those in the convalescent or recovered phase of the virus produce much lower levels of IgG than those in the acute phase. And what this tells us is that antibody testing might be underestimating the levels of exposure to SARS-CoV-2 in the general population, because some individuals don't produce detectable antibody responses at all, and others' antibody responses decline over time and may get to a point where they're not detectable several months after exposure to the virus.